Hello, it's Dr. Peter, Franz.
Hello. Good evening. Is it?
Good evening, Prof. Sri Mulyawan.
How are you? Yeah, how are you? I'm from Denpasar right now.
Yes, Prof.
It's 20 hours.
Good evening, Professor Sri Maliawan.
Good evening, how are you, Dr. Peter?
I'm just fine. Hopefully you are healthy and fine too.
Yeah, very fine and healthy, and we doing routine activity right now. There's come now Bali, as usual, very crowded right now.
You mean the visitors from abroad and also domestic visitors?
Yes. Also now
Yeah.
many foreigners already come to Bali.
Good.
Yeah.
We will get started very soon. Good morning, good afternoon, and good evening, dear all, and welcome to the 27th chapter of Surgical Forum webinar of the International College of Surgeons Indonesia section. First of all, on behalf of the International College of Surgeons Indonesia section, I would like to express my gratitude to our special speaker, Dr. Izabela Chudzicka-Strugala from the Poznan University of Medical Sciences, Poland. And also for the other speakers, Indra Mulyawan, oral and maxillofacial surgeon from the Indonesia section, and Professor Dr. Met Ito Puruhito, PhD. He is a cardiothoracic vascular surgeon from the Indonesia section. And for all participants and the World Executive Officer, Mr. Max Downham, Professor Lie-Kwan, the World President of ICS, and Professor Sri Maliawan, the President-elect of the Indonesian section, Professor Hendy Hendarto, the Scientific Vice President of the Indonesian section, Dr. Franciscus Arifin, the Secretary of the Indonesia section, and our IT team, Mr. Bimo and Ms. Dewi, and all dear participants. Again, thank you very much for your attendance and contributing in this webinar. And my name is Peter Johannes Manopo. I'm the coordinator of this webinar, and I will be your moderator. And for the first opportunity, I would like to invite Professor Sri Maliawan, the President-elect of the Indonesian section, to address the opening speech. Professor Sri Maliawan, the floor is yours.
Thank you, Dr. Peter. Good evening right now. To all of the participants now, we are appreciate that and proudly can perform the regular International College of Surgeons Indonesian section surgery forum. Now we come to this 27th chapter. Yeah, we have now a very distinguished speaker. We have three speakers. it's already introduction by Dr. Peter Manopo, and the first time here, Dr. Izabela, I'm sorry, Chudzicka-Strugala. Is that right?
Yeah, it's very good. Thank you very much. Okay.
Good evening, good afternoon, and good good night, good morning, Dr. Mac. It's very glad to see you again. Okay.
In the Poland now we have at 2 p.m. That good evening for you, good morning for the Max, and to somebody if we have somebody from Europe, but good afternoon. I will share my screen. Okay. Moment.
Wait a moment, please. Yeah.
Okay.
For the second opportunity, I would like to invite Mr. Max Downham from the World Executive Officer to address the ICS update. Mr. Max Downham, the floor is yours.
Oh, thank you, Dr. Manopo. Commendation, kudos to you, sir, for the 27th session of these ongoing webinars. I think I participated in 25 or 26. And so indeed, as Professor Maliawan indicated, you should be all of you in Indonesia should be very, very proud. It's my hope that other sections will emulate you in Indonesia. And there are people in Italy and in the Philippines who have conducted, and I think will be conducting webinars in the future. On behalf of ICS-World President, Professor Lie-Kwan, I greet the Indonesian section and certainly commend the section for all that you are doing. And it's my honor to be part of this. The update is the key point, I believe, is the World Health Assembly, which is the annual meeting of the World Health Organization, is next week. It will commence on Sunday afternoon and end, I believe, on the following Saturday. As you might suspect, a lot of time will be spent in general, in a few words, on lessons learned from the pandemic, and particularly on preparedness measures that can be followed in the future, given the possibility of similar pandemics. So that is the key point. Unfortunately, only 4 ICS fellows, and including myself, I'm not a fellow, are allowed to register because of renovation work occurring at the Palais des Nations. Nevertheless, the meeting ought to be very effective and I think informative. On Sunday afternoon, May 22nd, Dr. Izabela Chudzicka-Strugala, who is a speaker here with you this evening, your time, is the ICS European Federation Secretary. And Dr. Chudzicka-Strugala will be conducting an informal discussion on the challenges facing the European Federation and how we might make a bigger impact in the future. Dr. Chudzicka is a distinguished fellow of the college, and she is the European Federation Secretary. With that, with those words, Dr. Manopo, thank you for giving me an opportunity to speak. I'm always honored, and I turn it back to you.
Thank you very much, Mr. Max Downham, for addressing the updates of the ICS. For the next opportunity, I would like to invite the Scientific Vice President of Indonesia Section, Professor Hendy Endarto, to address the scientific notes. Professor Hendy Endarto, the floor is yours.
Thank you, Dr. Peter. Good evening, everybody. Good morning and good afternoon. Good to see you all. From the scientific note, I would like to inform you the short information about the interesting article that published online in JAMA Surgery, May 18, 2022. The title of the article is Technology and Surgical Training, Friend of Who, written by Vahan Nikolai. Nikolai stated that the role of technology in the patient care and surgical training continue to evolve. For educator, the rapid implementation of technology has been met with both enthusiasm and skepticism. Given the disruptive potential such rapid evolution may have, it is imperative that educators work to optimize the increasingly digital workplace to ensure that advances in technology are strategically implemented to enhance the trainee experience. Used optimally, learner-centered technology can help drive a competency-based curriculum. That's all I think about the scientific note. I hope we all stay safe and healthy. And finally, thank you for all the speakers for sharing your experience. Thank you very much for your attention.
Thank you very much, Professor Hendy Hendarto, for your scientific notes. And for the next, I would like to invite Dr. Franciscus Arifin, the section secretary, to address the section issues. Dr. Francisco Arifin, the floor is yours.
Thank you very much, Dr. Peter. Let me share you my slides. So, because this is a meeting of the ICS, even it's in the Indonesian section, I would like to take the opportunity to inform all of you, members of the ICS, especially for the Indonesian section ICS, how do we manage the ICS in the international community. So
excuse me, Dr. Franz.
Yes,
would you please put in the full screen size? Yeah.
Oh, okay.
It's small.
It's full screen. It's small. Oh, okay. Here is full screen, but just a moment. Is it full screen yet? No, yet, not yet.
Not yet.
Not yet. I'm so sorry.
Maybe at the
right
side.
Okay. I will start sharing again.
Yeah,
just a moment.
Okay.
Just a minute. Okay. Is this full screen? No.
Okay, no
full
problem.
Screen, Peter? Okay.
Yeah, it's okay.
Okay. So I'm sorry for the technical glitch. So we have an International Executive Council, and this International Executive Council is the governing body of the ICS. We have World President at the top of the Executive Council, and then Vice Presidents, World Corporate Secretary, and the member is also the sixth Federation Secretary, which manage the members in the countries according to the federation. So the next, sorry, okay. Now, there is also members of the Executive Council, which is not in the position of the secretary or the leadership, but these people are, these members have the rights to vote in the decision of the ICS. Now, we have a lot, I think 15 or 14 vice presidents. These are the vice presidents, and the extended council will include the vice presidents in the decision making of the ICS. And then we have 30 additional governors, which also represents the countries that are the members of the International College of Surgeons. Now, in these are the governors, and the representative at large will also represent and having a vote in the decision of the International College of Surgeons. Now, We have 6 federations. As you may know, that the African federations have 4 countries as a member: Cote d'Ivoire, Egypt, Ghana, and Nigeria. And the Asian federations, Hong Kong, India, Japan, Korea, People's Republic of China, and Taiwan. One of the common misconceptions for the Indonesian members are that Indonesia does not belong to the Asian federations. Rather, we belong to the Pacific Federation. So these are the most countries that includes in the European federations, the Latin American federations, the North American federations, which only consists of 2 countries, Mexico City and the United States. And here we in Indonesia are grouped with the Pacific federations, together with Australia, Philippines, Singapore, and Thailand. So we are preparing a federation meeting at Bali in August this year, and we invite. There will be scientific sessions also in the Pacific Federation meeting. So we invite all of the fellows of the Indonesian College of Surgeons and all who are interested in the scientific meetings. It will be conducted hybrid, online and offline, in August this year. That is all, I think. Short presentation of the ICS leadership. Thank you very much for the time. I return to you, Dr. Peter.
Thank you very much, Dr. Franciscus Arifin, for your informative presentation. And now we come to the scientific session. For the first opportunity, I would like to invite Dr. Indra Mulyawan. Excuse me. Yes, Dr. Indra Mulyawan. He is an oral maxillofacial surgeon from the Indonesian section, and he will talk on surgical management of odontogenic infection. Dr. Indra Mulyawan, the floor is yours.
Thank you, Dr. Peter. I want to share screen first.
Sure.
Yeah. Is it clearly?
Yeah, but please put on the full screen size.
Okay.
It is okay. Yeah, correct.
Is my voice is clearly, Doctor?
Yes.
Yeah.
Your voice is clear and your slide is clear.
Okay. Thank you, Dr. Peter. Good evening, Professor, Doctor, and all participants. My name is Indra Mulyawan, and I'm a lecturer from Universitas Airlangga, Surabaya. And today I would like not present, I think it's more sharing about surgical management of odontogenic infection. Yeah. As we know, odontogenic infection involve 3 causal factors, which are known as epidemiological triad as causal, consisting of agent, environment, and then host. Yeah. Those 3 factors must exist and relate each other to cause an odontogenic infection. Next. Yeah. Odontogenic infection port of entry consists of 3 main types. First, periapical abscess, which involve necrosis of the dental pulp, subsequent infection of the root canal, and second, periodontal abscess formed in association of periodontitis, and 3 is pericoronitis, which is an infection of the pericoronal soft tissue overlying the crown of a tooth. The large majority of odontogenic infection are of periapical origin. purulent infection associated with periapical origin is frequently described as a dental-alveolar abscess, although any pus-producing infection involving the teeth and surrounding supportive structure are often regarded as dental-alveolar abscess. Here is the percentage of distribution of anaerobe and aerobe bacterial causing odontogenic infection, which is with aerobe is 75% and anaerobe is 25%. So while the route of odontogenic infection can be divided into hematogenous by bloodstream and then lymphogen and per continuatum, depends on the thickness of the bone, muscle attachment, and affected tooth and root position. The next. Here's the pattern of odontogenic infection. Odontogenic infection can spread through primary fascia in maxilla and mandible, and also can spread through secondary fascia as well. And next. Now we are talking about the difference between edema, cellulitis, and abscess, where it can be shown by characteristic, and edema in this table, and cellulitis in this table, and also abscess in this table. So for speaking about management, some surgical treatment include incision, drainage, trepanation, and tooth extraction, followed by antimicrobial therapy and supportive treatment. So here's the picture of trepanation or opening pulp chamber to get access to root canal system. So we can see in this picture, we can make a trepanation in the root canal opening or open bore. As we know, an open bore. If the tooth has no good prognosis with root canal treatment, tooth extraction must be considered. It aims to make drainage and elimination the infection. So the surgical treatment, as we know, incision drainage is indicated only when pus has accumulated in the superficial soft tissue and have a fluctuation and puncture result is positive. So here's the anatomical landmark of extraoral and intraoral incision. So we can see in here the picture, where's the line where we can make an incision. So proper knowledge about vital structure regarding with vascular and nerve innervation is mandatory. The vital structure are the facial artery and the marginal mandibular nerve. Yeah, we can see the vascular and nerve innervation in here. So here's our case example about a man with Ludwig angina and compromised with a lot of medical diagnosis. 96 years old male with submental bilateral submandibular sublingual abscess, as we know, is Ludwig angina with type 2 diabetes mellitus, hypertension, post-CVA, on clopidogrel therapy, and impending airway obstruction. So first we do an anesthetic with PHKin injection, hence aiding hemostasis. So second, we incision, we draw the incision marking design. And then next, yeah, based on the line of Langer or relaxed skin tension lines. So the incision must follow the Langer lines to prevent any scar or fibrotic tissue in facial area. So next we do abscess incision. Following the most fluctuant point, we do the abscess incision. So next we do the post-culture specimen collection. and examine it in laboratorium. So next we do the exploration with the blunt dissection to open the access. And next we do the irrigation using povidone 10%. After that, we clearly by irrigation using NaCl 0.9%. And then after make sure that all of the has been removed, we put a rubber drain in there. So we put the drain placement in here, you can see. And then the rubber drain is fixated by suture. We have a multiple incision in here. And then immediate post-op, as we can see in the picture, we make a fixation by HyperFix. And this is the post-operative day, first day. The patient was in good condition with minimal post-discharge, and the patient was discharged and the second day post-operative while waiting for the microbiological culture. So here is the principle of antibiotic therapy: proper dosage and spectrum, and proper time interval, proper preparation, proper route of administration, and proper documentation. So as we can see, antibiotic commonly used in application to odontologic infection. We mostly use amoxicillin for the broad spectrum, and then here's the choice about amoxicillin and clavulanic acid, clindamycin, azithromycin, or ciprofloxacin, and combined with metronidazole or gentamicin and penicillin. So next, antibiotic prophylaxis against bacterial endocarditis in oral procedure. So we can using amoxicillin in indication for standard 1 hour before, ampicillin half hour before, and clindamycin. If the patient allergy to penicillin, we use 1 hour before, and then cefadroxil, if allergy, we can use 1 hour. Azithromycin or clarithromycin, we use 1 hour before, and or cefazolin, we use half hour before. So for combination of antibiotic used in some condition like this situation, so for the patient with condition mixed infection treatment, treatment for severe infection that have no clear cause, and choose drugs with mutually supportive pharmacodynamics, addictive effect, and then synergism effect. So last, supportive therapy consists of analgesic, nutrition, hydration, antipyretic, and antiseptic mouthwash. So thank you for your attention, Professor and Doctor, today. Have a nice day.
Thank you very much, Dr. Indra Mulyawan, oral and maxillofacial surgeon from the Indonesia section, for your informative presentation. We will get the discussion after all presentation will be completed. So for the next opportunity, I would like to invite our special guest speaker, Dr. Izabela Chudzicka-Strugala from Poland, and she will talk on the most common pathogens responsible for pressure ulcers after surgery and the treatment in outpatient setting. Dr. Chudzicka-Strugala, the floor is yours.
Okay, thank you very much. I hope that I'm hearing good. And now I would like to share my screen. I hope you see my screen.
Yes, clear.
That my subject is the most common pathogens responsible for the pressure ulcers after the surgery, and in the outpatient clinic. You have to know that you are the surgeons. But later we have a problem if in the outpatient clinic, because you send these patients to us and with sometimes with the pathogens and with the problems. But I will show you also my experience with my patients with the wound and with the infection after this. You have to know, everybody know, of course, that the problems with the infections, of course, the stuff, yes, in our hands and everything, in the source of the infections and the bad sterilized medication equipment, because still we have in the all world these problems, not only in the Europe but also in the Asia, Africa, America, and everywhere, and also with the vaccine, because we have to know that when we send our patient to home, we have to tell them about the change the dressing, sometimes the 2 times per day, or sometimes the 3 times per day. What is also the problems? Also the problems is with the when we have a problems with the wound, we have to always should be take some kinds of the swabs, and we have to culturing because we should know what kinds of a pathogen we have, and of course about what kinds of the antibiotics therapy we should use. That of course everything is perfect, but the most problem is the staff hand. During the 2 years, 2 years ago, was started the COVID, and I observed also in my clinic in the hospital, because I also worked in the hospital near the Poznan in the Czarnków. I observed the power to the washing the hands. We had only for the 3-4 months. Later, everybody forgot the washing the hands, and of course now it's still the bad, and also we observe it's the same in our patients. Okay, then there is factors, of course, in our patients, as you know, is the immunodeficiencies, the age, the elderly people. I have more problems with the elderly people, not on the newborns, and the diabetes people, all the people with some kinds of also the vessels problems of the knee. Nursing of the doctors, I told before, but of course, you know everything about this. Time of the hospitalization, what I saw, of course, it depends from also the country and also with the procedure. But sometimes I show that the patients in the hospital when been the 2 of 3 weeks after the 2 or 3 weeks after the surgeons. I don't understand why it was, and of course after this we have more problems with the complication and the contamination with wounds, and later this patient sent to the home and we have a problem. Of course, to come back to the surgeon sometimes is impossible, because of course we have not sorry. We are the international college of surgeons, but we still need more and more surgeons. And catheterization on the of course the vessels and the bladder is also the problems with the infections of these wounds after the surgical treatment. But still we have problems. Yes, we have 3 groups of the infections. You know, that depend on the patients, depend on the surgeons, and also of the hospital environment. And the sanitary conditions is very important because we have very modern the hospital, and also very old hospital. The same we have in the Poland problems because we can see difference between the very modern hospital and the old hospital, like the more 100 years old, because we can do everything, but you have to know something is the problem. Also with the connection between the unit. And about the 25 hospital infections can cause infections after the surgical way and treatment, and we have a problem. But the symptoms is when we have an infection of the wounds, we can think about the diagnosis must be the base of a bacteriological testing. Because we're giving sometimes the antibiotics, we're giving some kinds of the anti-inflammation, also the medications. But of course, when we give 2 antibiotics on the blind, sometimes we can not help our patient, we can have a longer treatment because our patient can be developing as a super bacteria, but we have to know about what kinds of antibiotics is really sensitive to our bacteria, because as you know, for example, as here, we can have a different pathogens, the aerobes and the anaerobes position, the condition. But of course, when we have a purulent discharge, when we have a fever more 38, when we have a tension, the tension, we have a lot of the anaerobes pathogens, swelling of a spreading erythema, of course, we should always use the bacteriological material to the culture. Of course, everybody wish have a like this condition after the operation because it's very beautiful after the condition. But the wounds, we have a clean wounds, we have a contaminated wounds, we have a dirty wounds, of course, and with this dirty wounds, we can have a problems with the different pathogen. What pathogen? It's the Staph aureus and the Staph epidermidis. This pathogen belongs to the gram-positive cocci. That Staphylococcus aureus, of course, I will show you on the next picture, but of course, it's important here to know if we have a MRSA, methicillin resistant Staphylococcus aureus, because you have to know that we have to give another antibiotics like the vancomycin and also the teicoplanin. But also the same we have in the Staphylococcus epidermidis when we can have a MRSE, but it, of course, after the Staphylococcus epidermidis, we can have a developing the biofilm, yes, during the, for example, also the implantation, that biofilm in the implantation, you know, that everybody afraid, yes, because we can have a reimplantation. Pseudomonas aeruginosa is the same, also released the biofilm, but has a Alginian capsule, and it belongs to the gram-negative pathogen, Citrobacter frundi, Proteus, E. coli, and Klebsiella pneumonia belong to the Enterobacterales, but of course also we can observe very big problems with the wound infections. And of course what I observed in my patients after the operation and after the hospital, but of course stuff is normal, yes, but the stuff is okay, but of course the Proteus on the wounds and also the Citrobacter on the wounds is very big problem, but also Pseudomonas aeruginosa. I met the two patients with the Bacteroides fragilis and the Clostridium perfringens in my open clinic, outpatient clinic. That of course it was the one patient died because it was after the 3 weeks fighting later in the hospital, and because this lady, it was lady, she don't want to go to the hospital, but we fight it, but with her to give the challenge. It was a big challenge, for example, to give antibiotics to the treating, to the cleaning the wounds by the one more surgeon way. But the Staphylococcus aureus and epidermidis one more times, of course, we have a gram-positive cocci. But what I would like to, of course, also told to everybody, not only the surgeon, also to the another doctors. Please observe if our patient has not some kinds of the, for example, on the skin, some kinds of the abscesses, furunculus, also please take from the nose, if we can take from the nose the carrier before the operation, because it's very important for us later to the treatment. Maybe we will have not contamination the wounds. Also like the impetigo, yes, of course I understand that we have to use some kinds of the medication, but and we have a very fast operation, but please remember about this, that of course before this maybe the first give the antibiotics and later give the using the surgeons. Skin infections, when we have a surgeon, when you have a nurses, for example, a lot of nurses can have some kinds of problems with even the nails, of course should be go away from the surgeon's staff, because maybe later, because we can also spread by other had, I understand that we are using the gloves somewhere, and also surgeon now using the 2 times the gloves, but of course it's still the problems with the contamination and the spreading, the transferring the bacteria. And necrotizing vasculitis, you know, we had one patient, this was the young lady in the Poland, it was in the gynecological clinic, but of course now it's okay, but she used she was in the pregnancy, and she had the problems with the she had this from the during the contact sex, she had the problems with these infections. In the Enterobacteriales, I told you, but the most problems we have with the KPC, carbapenemase, Klebsiella pneumoniae, NDM with New Delhi, 48. But what is important, the gram, of course, gram-negative, but on the surface we have a lipopolysaccharide, which is the endotoxin and developing the endotoxic shock. And also this bacteria has a flagella, but it's very, very difficult to remove. But sometimes we, in the outpatient clinic, we are giving that sometimes a lot of times the course of the antibiotics, but we cooperated with the surgeons, for example, the cleaning, because you can see here, for example, it's caused by the serratia, of course, with the surgeons to one more time clean this yes, and also you have edema during the vessels problems with also the serratia marcescens. What I would like to show, this is my now patients from my here. This is the patient which go out from the hospital, and I also told them about the some kinds of equipment. The equipment was this lady had free over 4 days and went to the home. Later, of course, she was after the broken the head, and she had this equipment 3-4 days in the hospital, and later went to the home with of course the opening the wound. But this is the directive way for the developing the infection of the wounds, and of course the cleaning of another. We change everything at home very, very soon, but of course it's she can transfer from the hospital to home also the bacteria. But this is the on this picture you can see my patient which has developing the small wounds. It was all the first time it was the 1 centimeter. This patient went to a lot of time to the surgeon, the first to the dermatologist, not help, it's the still bigger and bigger. Later went to the surgeons and not help, I don't know why. And of course it came to me, to my outpatient. I opened my house because it's for me it's abnormal, yes, and of course I sent very soon, very fast to the hospital. I call it to the hospital, to the operation, to remove this. This is was very big abscesses with a big inside. If you will see on the inside, it was a lot of pus. It was some kinds when we culturing. It was the stuff. It was the Pseudomonas aeruginosa, and also it was started with the Bacillus fragilis. It was the contamination. The patient still had a lot of the temperature between the 38 and the 38.5. And when came to me, I call it to everybody to help this patient because it was impossible to with what not doing with this patient. What is the problem with this patient? This patient was the homeless. It was she been in the shelter and with the homeless. And when he came to me, I told him why so late. He told that he looking for a microbiologist a long time. But I am in Poznan, but I called it's good way to do. But you come to me. Okay, but now I would like to show you another problems. Also the patients which the first had the problems with the vessels. This patient had the operations on the vessels, and now vesiculoria, and now developing the Pseudomonas aeruginosa with the candidosis. I gave very soon the antibiotics and come back to the surgeons because always we have to cooperate with the surgeons. Of course, to remove the nails and also one more times the treatment. This patient had problems with also the leg, but came after the broken the leg, after the everything doing. Of course, this patient developing the Staphylococcus aureus infection. That is was the problem. I asked it why, and she told only he was the 4 days in the hospitals, and after the hospital it was like this. But I don't know, I don't understand what happened. But of course, after the antibiotics course of antibiotics therapy, the 2 months it was good. And also during the vesical problems, of course, is developing. That I always told antibiotics course it's okay, but of course we have to go to the vessel surgeons, because we have to help you, because always you will have open this wounds. And it was one of my patients sent to the home after the hospital with the bed sores. And when I saw this, it was horrible. I don't know. The first time I not believe that she can go to the home from the hospital. Yes, this patient also has catheters. Of course, she is still alive. We helped her. We cleaning all the wounds. I told you what we had. The first, of course, I done everything. It was for me. It was horrible because we have a Clostridium perfringens, as you can see, because the smelling is but not but Bacillus fragilis. But the first was the Staph enterobacterialis and Pseudomonas aeruginosa. What I'm doing, I like this situation. I am giving, of course, the antibiotics per os and intramusculare, but of course you can see that musculare in the bottom is impossible. That of course I am giving also some kinds. I'm using here the eye drops. Why? Because the eye drop is the sterilizing. Yes, that I am using the eye drops to the giving on the outside this cleaning this. And treating this wound. Later, of course, if possible, I am opening the injection antibiotics, but of course, intramuscular is the one, but the second one, I am cleaning by look like the water, yes, in the injection, but we are duration the injection antibiotics also is the sterilizing, and we are cleaning. And of course, on the first time, we are close by some kinds of the dressing with the argentum. But later, when it was possible, I told open the wounds to minimize the oxygen, to not developing the more Clostridium and the Bacteroides. And of course, after the everything, this lady now is very good. Because, of course, I sent the one more time to the hospital. They cleaning me one more times, and now this lady has bed sores only on the 2 centimeters. I hope the next 2 months will be very good. But of course, we close also in the after the everything cleaning, after the everything treating, and the shoe it's now should be perfect. But I never believe that I can see like with the sores, because I saw a lot, but like this never. About the Pseudomonas aeruginosa, why I would like to tell about this, because you have to know is the gram-negative rods with this LPS that I told before, but produces the biofilm. And my patient, after the surgeon, I always told not going to the jacuzzi, not going to the bath, to the swimming pool, because you can have a lot in this places. We have a lot of problems with the bacteria, a lot of problems with the Pseudomonas aeruginosa, with very good growing in the 37 degrees Celsius. That of course we have this in the jacuzzi. But if you would like to have a jacuzzi, of course, not now, after maybe the 1 year, if everything will be the close. The same I told to pregnancy woman, to another patient, but especially after the all surgeons, not after only some kinds of another, but special, but after the all surgeons, I thought not going to this. That would be in the infection during the Pseudomonas aeruginosa, as you know, is the specified smelling. It looks like the flower smelling, somebody to like it this. And of course, with the pus, we have like the green of the, it's more like the green pus, yes. And also it's my own pictures. which you can see is the problems with the leg, and also the problems with the foot. It's the problems with everything. You can see the opening during the, of course, the diabetes. I also sent the first time to my patient, to the surgeons to clean this. Later we give the antibiotics. Later we give the, well, like I told, Argentum. We use it also the, give me 5 minutes more, okay? The Argentum also giving the antibiotics. It was dependent from the antibiotic therapy. Some special antibiotics for this for the microbes, and later it was, now it's okay because also the wound is only very small, and we are waiting for the really half. But this patient, what I told, this patient died. This patient we sent 3 times to hospital. This patient fighting with us. He don't want it, but when he had a 39 degree and still growing, I told not to discuss. Went to the hospital. After the 3 weeks, this patient died. But of course, this patient had it was after the infarct cordis. He was also with the problems with the neurological problems. This patient had also the diabetes, the problems with the vessels problems. But of course, we're fighting with everything, not just only with the infections. But the infection was one of the way to the diabetes patient. But it was also the mix of the pathogen, but on the ending it was the Bacteroides fragilis. But of course, you know how it's very difficult to give him the antibiotics. And of course, we talking about the amputations, but of course, but this patient and the family told no to do nothing. Diagnosis test is always important, what I told you, but we would like to know which kinds of the pathogen we have, and also what kinds of the antibiotics you would like to do. But rationality antibiotics therapy is very important. But of course, the rationality, we have to know what kinds of antibiotics we have to give, but after the bacteriological material, after the making the sensitive testing, of course we can give very good antibiotics. But we are using the same on the all world, yes, octenicept over some kinds of to the cleaning wounds, and also with some kinds of ungventum, some kinds of of course the dressing with the argentum is very good. But of course, I told you I very like the not in ungventum. I am more like the eye drops, because with the antibiotics, because I know that this is the sterilized antibiotics that of course I can give directly on the wound. But of course, antibiotics by the injection, by the oral also is sometimes very important, but a lot of times very important to the faster helping these patients, and of course to the close the inflammations. And I told one more time, we have a lot of antibiotics in our food. You know that the all food, all the meat, also now the fish, also the vegetables we have with the antibiotics. Yes, but when we would like to sometimes be giving the antibiotics, of course we observe the resistance very soon, but we can developing the superbacteria, and sometimes we have nothing to do, and we can do nothing with our patient. I would like to thank you very much, and infection control is very important. And for example, I see that outpatient clinic, but family practice and the microbiologist is very big close with the surgeons, and I am happy that I am very close with the surgeons, because they help me very a lot of times with the cleaning the wounds, and later I can do what I would like to have on the finish that my patient is we can have. It's my references, and very thank you very much for your attention.
Thank you very much, Dr. Chudzicka-Strugala, for your very nice presentation. We will have discussion after our presentation will be completed.
Wow.
So
Okay.
for the next, thank you. So for the next opportunity, I would like to invite Professor Dr. Matt Ito Puruhito, PhD. He is a cardiothoracic and vascular surgeon, and he will talk on the surgical management in rib fractures. Professor Puruhito, the floor is yours.
Thank you very much, Dr. Peter. Is my voice okay?
Yeah, your voice is clear and your slides is clear too.
Okay, thank you very much for the invitation for me to speak in this forum. Good evening or good afternoon in Europe and good morning in America, Dr. Max Dohan, and good evening for everybody here in Indonesia. What I'd like to speak today is to share also with you how the latest management or the latest policy in rib fractures. If we learn from Google search, we can find that actually simple or isolated rib fractures, the treatment is just conservative treatment and is adequate. Of course, it should include appropriate analgesia, rest, and ice. And if somebody has the spirometer, you can use it or give it to the patient to train his respiratory exercise. Secondly, the core management of rib fracture consists of 4 areas. The first is damage control. Second is pain management. Third is fixation selection. And fourth, the quality of life. Next, we also learn from Google search, the pre-hospital care consists mostly of airway maintenance and suspended oxygen. That's what the paramedics should give to the victims with rib fractures. But as soon as the patient entered the emergency department, then the care should be taken by using stabilization of the trauma and the multi-system area, and also the pain control. That's what we can learn from Google search. So what are the challenges in rib fractures? Let's see first about the pathophysiology. The ribs will break at the point of impact and mostly in posterior angle because it's the weakest structural point. If the first and third rib are fractured, actually it's relatively protected, so it's very seldom. But if it's fractured, that should be a higher association with severe intrathoracic injury. So beware, if the first and third rib are fractured, there is a possibility of intrathoracic injury. Also, the 9th and the 12th ribs, if fractured, whereas it's more mobile, there is an association with intra-abdominal injury. The right-sided rib fracture has 3 times likely to have hepatic injury, and the left side rib fracture has 4 times likely to have splenic injury. And in adults, fractures is more common, so children have less possibility to have rib fractures. And multiple rib fractures, 2 or more, is always associated with higher incidence of internal injury, mostly abdominal or even the thoracic injury. And elderly patients with multiple rib fractures have 5-fold increase in mortality compared with younger patients. If we take the age of 65. Second, pathophysiology will say that the pain from rib fracture can cause respiratory splinting and can result in atelectasis and pneumonia. And multiple continuous rib fractures, for example, if there is a evidence of flail chest, interfere normal costovertebral and diaphragmatic muscle excursion. So it is potentially causing ventilatory insufficiency, leading to pneumonia or to adult acute respiratory distress syndrome. If there is a fragments of fracture rib, it also penetrate to the lung and will give to situation where there is a blood in the thoracic cavity or hemothorax or just a pneumothorax. And a single blow of rib fracture, mostly are victims of bomb explosion, for example, can make multiple rib fractures. And mostly are occur at the site of impact or the postural band, where the ribs is the weakest point. How about the clinical facts? Number 2, rib fractures were caused mostly by blunt thoracic trauma, not the penetrating injury. Once again, the first and the third rib can fracture only with high energy impact. So there is a probability causing a lung injury beneath the rib. So it is a challenge. Secondly, the fourth to ninth rib are often fractured, but it is less challenging because it is easily to detect and mostly fractures on that side. But the ninth and 12th rib fracture are seldom, but can carry through the trauma energy to the inner organ, and if fractured, it can lead to trauma of the liver and spleen. So this is a big challenge. Those are a point of challenges in rib fractures. And of course, hypoventilation occurs due to the pain, and once again, is also a challenge. But unfortunately, numerous studies have shown that without direct evidence of vascular or neurologic compromise, fractures of the first and second rib is not associated with increased mortality. But however, the multiple rib fractures that include the first and second rib associated with tenfold increase in mortality if it is fractured and if there is a trauma of the beneath organ of the first and second rib. The clinical complication consists of respiratory failure because there is a hindrance of the mechanics of the respiration during rib fracture due to the pain. They will cause hypoventilation, hypercapnia, hypoxia, atelectasis, and of course leading to pneumonia. And it is one of the most common complications associated with rib fracture. And of course, if there is a severe trauma, the underlying visceral organ could be also damaged. Mostly, pneumothorax happen immediately or even delayed. The same with hemothorax, immediate or delayed. Also with aortic injury. So should beware if there is a possibility of aortic injury, and of course the pulmonary congestion. And these are the most challenging problem in rib fracture. So we can see here, for example, a fracture of the left side of a victim, of a patient, which shows fractures of the 5th, 6th, 7th, 8th of ribs. But you can see on the right side, there's also a pneumothorax. So even the trauma is on the left side, it could also damage the right side of the lung. So it should be beware if you should see also the other side of the thoracic cavity, not only the damaged side of the thoracic cavity. How about surgical care? I just mentioned the paper written by Kasutakis and other authors. They make a meta-analysis of 22 studies of patients with rib fractures and shows that the ORIF, or open reduction of fracture, achieve a lower mortality, shorter duration of mechanical ventilation, and also length of hospital stay, and a decreased incidence of pneumonia. So we will show you that actually the surgical care is more beneficial than the conservative care. What is the basic management of rib fracture? Number one, the diagnostic measure consists of X-ray. It is using the low level of radiation, but however, a chest radiograph limited and sometimes can only diagnose about just 50% of isolated rib fracture. So the point of care ultrasonography can really detect the rib fracture. It is more easy to do the ultrasonography, but actually choice of experiment is the CT scan, because CT scan can uncover most of rib fracture compared to that normal X-ray. And most of the rib fracture are diagnosable through a clinical exam. Just to put and make a palpation, patient will say it's painful, and there is the location of the fracture. And this is what is the East Trauma Practice Guideline recognized the surgical fixation as level 3 recommendation of plain chest, because after diagnosed by CT scan and we can see a lot of fractures in several sites, then we will see also that there is some important to do the surgical management. You see here the example of a normal X-ray, which we can see also clearly fracture. Also, if we do the CT scan, then we can see also the fractures of the rib more clear. This is the water sleep planning. What is the first case management? Number one, as I say before, pain relief. And to relieve the pain, somebody can consider to perform a fixation of the fractured rib by putting rows of adhesive plaster like this patient. Just put a row of adhesive plaster on the side of fractured rib, and it will make the pain less. Yeah. The challenge is, of course, you have to put that adhesive plaster during expiration and not during inspiration. Of course, we can next do the pain relief by considering to perform analgesia directly to the site of the fracture, like this picture here, or to the intercostal nerve, which is the technical detail and shown here. That number one, you just hit the needle to the lower part of the rib and make angling downwards and try to hit the intercostal nerve. Before that, you have to aspire the sirens not to hit the blood vessel, but the challenge is, of course, to hit exactly to the nerve. And this is a second consideration of doing the pain control. There is, of course, some special cases, like what you can see here with open chest. So rib fracture with open chest or with frail chest, like this one. So you can see clearly, this is a community fracture of several places of rib and causing a frail chest. The schematic drawing would look like this one, for example. This is the frail chest. Now, I'm talking about how to fix make a fixation of the rib fracture. There are several techniques. Plating with bicortical screws, or plating with absorbable material, or jute struts or jute-like struts, or Kirschner wire, and intramedullary rods or splint. But in this occasion, I would like to introduce what we do in Surabaya. We are using the so-called SHAP, S-H-A-P-P, Costafix, and lately SHAPI. I will explain briefly. But as told by the several references, no method or no technique was found to be superior compared to others or so far. So it depends on you which technique you will choose about this. I will show you what is the SHAP Costafix developed by us in our department. It's patented in 2002. This is the plate with 4 legs. This is the clamp to bend that lips, and also some appliances. And the name SHAP consists from our staff. Those 3 gentlemen has already passed away. The rest is still myself and Dr. Paul Taleri. It is registered trademark in 2002, and we have developed the name by Costafix SHAP. This is the technique. Surgical technique is very easy. Just open the chest wall, look for the fracture, try to repair, redo, or replace the fracture, and put that clip on that and just press with this special clamp, and it is will fix like this. We can put 1, 2, 3, or in several places, even together with a clavicle fracture done by the orthopedic surgeon, of course, or in a row of rib. So there are 8 legs together, and even 5 or even 10. And recently, in 2017, we tried to develop with 6 legs like this, not only 4, with a more better metal. And because it's Shopee, because we put extra 2 our staff, Heru Subroto and Jan, so the name is now Shopee, Costa FICS or Shop, which is 4 legs, and Shopee is 6 legs, and it looks like this, or single, or even 3 ribs together. We can see here the radiographic examination after the implantation of the Shopee with the 6 legs, 3 of course, or even posterior side. So in summary, number 1, most rib fractures are not life-threatening, but fewer than 3 ribs fractures, sometimes if there is no displacement, there's no operative treatment necessary. Of course, if there is no associated organ injuries. But traditional conservative management aims to adequate pain control. The stabilization of rib now is important. There are some technologies developed, including what I've just shown before, what we are doing in Surabaya. And recent studies support that the surgical stabilization has more benefits over the conservative treatment. So it will shorten the hospital stay, reduction of the pain, also ICU time, also to avoid tracheostomy rate, and also pulmonary infection rate. Second summary, in surgically treated patient, fixation often must not be carried out in all sites. So you need not to fix all of the fractures. Yeah, it's enough 2 or 3. What is mostly fractured and unstable. Fractures of the free-floating ribs, the 9 and the 12, are not recommended to be fixed unless associated with liver or spine injuries. In flat chest, you can just stabilize 1 or 2 of the fractured rib, not necessarily all of the fractures should be fixed, because it is enough if you just stabilize 1 row or 2 rows of ribs if there is a flat chest. So take-home message, I would like to say that rib fractures are the most common traumatic injuries after chest wall trauma. Secondly, after primary and secondary surveys, the patient condition should be further optimized by efficient pain control and aggressive pulmonary hygiene. And as part of the secondary survey, all thoracic trauma should get a chest X-ray. However, the modality can miss up to 50% of pneumothorax and more than 50% of rib fracture. So sometimes X-ray is not enough. You should do a CT scan. Therefore, CT scan plays an essential role in the diagnostic thoracic trauma injuries. So to end up my speech, I would like to mention that the computer technology has also advances in fixation of the ribs. Like I shown in this picture, that Photoshop can fix a broken rib, but just in the X-ray picture. Thank you very much for your attention. I give back to Dr. Peter.
Thank you very much, Professor Ito Puruhito, for your fruitful presentation. And now we come to the discussion session. But before opening the discussion to the floor, I would like to allow the speakers to make a short discussion each other. So each speaker may ask question to the other speaker. So I will give the first opportunity to Dr. Chudzicka-Strugala to ask question to the other speaker. Dr. Chudzicka, the floor is yours. Dr. Chudzicka, are you on the line?
Moment, I'm here. I'm still here.
Yes, you can ask question to the other speaker, or maybe you can provide feedback. So you can choose.
Yeah, I will discuss, show my problems. Not only my, everybody we have the same problems. Maybe you can tell me how to do it, or how to much more close the close the surgeons and family doctors, because I probably see the same problems. I understand the surgeons also go to the outpatient clinic and the something do it, but of course sometimes it's impossible. But maybe you can tell what we can do in the family practice to how many ways we can do and not need your as a surgeons.
Okay, this question, which would you like to address this question? The first speaker or the third speaker?
No, maybe to the first speaker. No, to the third speaker.
To the first speaker. Okay, Dr. Indrawan, please react to this question to Dr. Chudzicka-Strugala. Dr. Indrawan, are you on the line?
Maybe
Dr. Indrawan.
You're muting, Dr. Indra, Mulyawan.
Oh, yeah, because I understand you, because it's the problems with the connection sometimes.
Yes, doctor.
Yeah. Dr. Chudzicka-Strugala asks about your experience regarding of her pathogens that responsible for the ulcer, or maybe in your case. Would you please react for his question?
Maybe
What pathogens do you have in your cases?
Maybe one to the first patients, okay, to the first speaker. You told about the oral cavity problems and also the odontogenic problems. Maybe I have a question to you. Please tell me what kinds of antibiotics I should give on the first line to my patients on the outpatient clinic when go to your odontological problems with the wounds, because a lot of patients came to me, asked me with the problems with the oral cavity, and later I think amoxicillin does maybe better when.
Yeah, Dr. Indra, would you please react to the question of Dr. Chudzicka-Strugala?
Yeah. So for the first line, I think we use the amoxicillin, and then if there are any infection in the ulcer or maybe in the infection, we can use a culture examination, and then we examination in the lab, and we know the sensitive antibiotic for the cases. And I think for the second, we can use clindamycin or maybe cefadroxil or anything like that, Professor. Doctor.
Okay, thank you. But we are using the same, because my question is, because of course the connection with the dentistry doctor in Poland we have not too close. But of course we have. But patient asked me very soon, before going to you, what I can do. But very, very good. Thank you very much for your helping, because the amoxicillin. Okay, but I changed it.
Yeah.
Thank you, Dr. Chudzicka-Strugala and Dr. Indra.
Yeah.
For the next opportunity, For Professor Puruhito, do you have any question to the other speaker?
Yes, ask Dr. Strugala. How about the infection if it is concerning with the diabetes patient with vascular involvement? For example, high risk of diabetes with atherosclerosis and have infection of the foot, diabetic foot infection. What is the first choice of antibiotic in your opinion? Because we have a lot of those patients coming to our outpatient department.
Yeah, it's really big problem because diabetes really bad problems. But of course, we divided the patients on the two groups with the diabetes with normalization on the glucose, and it's no problem. And of course, with the different level of the diabetes, it's different of the glucose. And when we have a wound, of course, and the arteriosclerosis of the vessels and also the wounds, the first I would like to when we have a wound, I would like to send to surgeons to help me. Of course, sometimes it's impossible because the waiting on to the surgeon is very long. But of course, I call it to you as to specialists, and they tell me what we have to do in the outpatient clinic. But it's still much big problem because you know that diabetes now is the civilization diseases, and too many patients now it's has a problems. Antibiotics.
Dr. Strugala. Yeah. If we the amputation, should we take after the amputation is done?
Yeah, of course, but that is after the amputation because it depends from the wound. But of course, after the amputation, we are giving the ovocephtriaxone. This is the third generation of the cephalosporin. It's been very good. But of course, we're also giving the fluoroquinolones, like the ciprofloxacin or the levofloxacin. Because we observe it's very, very good. But the first we are starting with the ceftriaxone, with the third generation of the cephalosporins.
Okay, thank you very much. Thank you.
Thank you, Professor Puruhito and Dr. Strugala. For the next opportunity, please, Dr. Indra, do you have any question to the other speaker? The time is yours.
Yes, okay, Dr. Peter, thank you for your opportunity. I want to ask Puruhito, Prof. Puruhito, excuse me. Yeah, Prof. Puruhito, I have a question. In mostly cases in oral maxillofacial surgery, we do a joint operation with thoracic cardiovascular surgeon for taking a graft costae. And I want to ask you, how about the defect of the costae that we take from the patient? What we should do, or what happened next with the defect of that? Thank you.
Well, to answer your question, if I just making a joke, don't worry, because the God, what? the first woman from the first rib to taking the rib. So if we take one rib, there is no problem to fix it again. So it's okay, no problem if we just take away the rib to make a transplant to the mandible for the oral surgeon, and the rib will stay there. It's not fractured, so it will heal spontaneously. Just the patient has less one rib. Maybe he has more wife then. I don't know.
even with the costo control, Professor.
Yes, because I know that you need that chondral fraction to fix the mandible. So mostly we are using to take away the 7 or the 8 ribs where it is hanging, not hanging. The 9 to the 12 rib is a hanging rib, so we cannot use that. So we take the arcus of the costae, and there is the part of the rib together with the osteal part of the rib to supply to the oral surgeon. So there's no problem.
Okay, yeah. Thank you, Professor.
And open the discussion Is there any question from the floor? Maybe I will give the opportunity to Professor Hendy Hendarto. Do you have any question? To Doctor, do you have any question?
Yes. Can I ask Professor Itza and Professor Puruhito? Both of are very interesting, giving very interesting lectures. The first one for Professor Chudzicka-Strugala. I would like to know, do you have any experience contamination of the wound or abdominal? So we have many of open wounds, especially after peritonitis, and the wound does not heal even if the contamination from the abdomen is clear. So so the soft tissue infection is not healing very well. So there is a lot. There's still a production of pus and serous product from the wound, especially if the patient is fat or very the fat layer is very thick. So do you have any suggestion? Because usually we just wait and clear the wound copiously many times and wait. Or do you think in these cases you would have to give antibiotics? So this is a sufficient injury.
I told you what I showed you my wounds also with my patients. Of course, my experience, what I am doing with my patients around this wound when I giving a small injection with the antibiotics, yes, not only intramuscular, but additional other antibiotics in the small around these wounds, because it's very much faster working with antibiotics in the close of this wound and not past discharge, because the problem with the past discharge, as you told, with the fat patient is the very big problems. And also, if the wound is open, what I told you, I use this ICS because we have a we have a macro line, we have some another, but of course I use eye drops because I can put all with drops. One bottle of the eye drops I can put on the all wounds and will be very fast doing. Also, please, also in the eye drops I connected with the steroids. For example, mycin or the tobramycin with the steroid, because I would like to close and the faster finish the inflammation. Because not only the problem with the bacteria, but problem is also with the inflammation. Yes, but steroid will be doing the faster treatment and the faster treatment.
So it's a local treatment, not a systemic antibiotics. Rather, it's a local
antibiotic in the one way.
Oh, okay.
Yes, but for example, in the systemic antibiotics, for example, I am giving the amoxicillin. Yeah. But in the local, I'm changing over on another groups. Yes. For example, when I have what I have, over metronidazole, over with the clindamycin, over ciprofloxacin, and around on this wounds. It's very, very fast. I have a result.
Okay. Thank you very much, Prof.
And your
the
second question? Yes.
Yes, to Professor Puruhito, my teacher. Prof, if I'm not mistaken, when we are still studying as a surgeon, a general surgeon, that posterior ribs are very stable, so it is not necessary to put the fixation even if it is fractured. But you mentioned in your presentation that nowadays treatment of rib fractures anywhere except for the ribs has a better outcomes. Would you kindly explain, is it a change of a policy, or is it a change of research of development in the current era? Thank you.
Okay, So just easily to explain. You are right. The posterior side is stable. So in the old times, people are thinking not to fix it. But if the rib are multiple fracture, more than 3 or 4, and if there is a injury of the lung, for example, hematothorax or even pneumothorax, then we should consider to fix the ribs, the fracture rib, even in the posterior side. Sometimes it's necessary to really the patient should be asked just to lie down, stabilization of the rib. It will take a longer time. So the aim of the surgical intervention is now to shorten the hospital stay and to prevent a patient from having a pneumonia or another further diseases. So now it's possible only 1 or 2 fractures, you can leave it alone without fixing the rib on the posterior side. But if it's more than 3 or 4, sometimes it is even ribs are broken in our cases, yeah, because the traffic accident now is more cruel than in the old time. You see sometimes bicyclists hit by a truck. So really the damage is very severe. So we need to fix it to help the patient getting out from the pain and also from the prolonged stay. The trend, the management of the repair.
Thank you very much.
Yeah, Dr. Franz and Prof. Puruhito. Other question from the floor? While waiting, I would like to address my question first to Dr. Strugala. Based on your experience, did you use for topical treatment of the soft tissue infection with povidone iodine or chlorhexidine or cetrimide, or you just like you mentioned by eye drop? And the second question for you is that the eye drop based on your experience, or is it an evidence-based treatment? Because
No.
I hear this for the first time. You use the eye drop for the wound care, but you don't mention any any other antiseptic solution like povidone iodine or chlorhexidine or cetrimide instead of eye drop solution.
Okay, I showed you during my presentation, but always before I have to use that antiseptic, yes? For example, octanidine, because it's very good. In Poland, we have most time using the octanidine. Iodine solution, we are not using on the outpatient clinic. We are using only in the hospital. But octanidine is for everywhere, but we can use it. And of course, later I can use, but I showed you, but before but doing the some kind eye drops on the another, I using the disinfectant, it look like the disinfectant, octanidine, and later, of course, my treatment by the antibiotics with the steroids. Because I have to clean this wound, yeah? Everybody have to clean this wounds. But before doing something, of course, we have to do with octanidine.
And how about the eye drop? Is it a evidence-based treatment or just based on the experience?
This is my own experience. Because I had a lot of patients, and I, of course, doing this, and I decided to using this patients because only this, because ungüentum, we have an ungüentum for the skin, it's not sterilizing. But you know that the eye drops, it should be very, very sterilized, the antibiotic with my hands, and everybody know that they some come to me, give me this eye is working.
Yeah, and the last question is about the steroid you use for the infection process. on my knowledge that steroid will inhibit the inflammation process for the wound healing. So while you use it in the ongoing infection, you use the steroid, it will harm the healing process. Do you have any comment of this problem?
We observe a lot of times, but when we started with problems with the big wounds and also the pain and evacuation, when we're giving the steroids, is the faster be the results. Of course, after the 6-5 days, we turn off the steroids because we don't need, because the wound is much cleaner and also not inflammation, not too red, not too swollen, because we would like to minimizing the swollen and the redness, yes. But of course, after this, we can turn off the steroids and later only just to giving the antibiotics. But of course, also rationality antibiotics therapy, because when we will give still the 2 months antibiotics, the antibiotics also will be not working. But we check it one more time. So we are taking the swab from the wounds, and if they're clean, it's okay. We are only also
Thank you. Yeah. Thanks, Strugala. And for the next question is, I would like to address to Dr. Indrawan. Dr. Indrawan, based on your experience, if you treat the abscess of odontogenic abscess, should you take out the focus of infection like the teeth, the damaged tooth or teeth, or you should preserve the tooth as long as it's possible?
Okay, thank you, Dr. Peter. Of course, we have to remove the source of infection, and then, or maybe if the teeth or maybe the tooth or mucosa in there, we can treat properly. We can treat properly, like maybe like make a in the root canal treatment and like apex dissection and then so on.
Choice is to preserve the tooth.
Yes,
and
the first choice.
Yeah,
the first
okay.
choice is to preserve if possible.
Yeah. So, and then my last question to Professor Puruhito: if you use open reduction for the treatment of the rib fracture, for how long you will leave the implant inside, or you should take it out after 1 or more years after put the plate on the ribs? Sorry, you are still muted, Professor Puruhito. Please unmute your microphone.
Great. Okay, thank you. So there is no need to take the what is it? The clip
Plate.
unless the patient is asking for that, or if there is an infection. And it is not easy to remove the, of course, after several times. Most until now, our statistics show that there is only around 2 to 3% of the patients who are asking to take out the clips after they are complaining, sometimes complaining uncomfortable feeling on the side of the fracture rib. Just that, but there is no need to take out the clips after several times. It will stay there.
So the screw or the edge of the plate will not damage the parietal pleura.
No, that's what the our construction was made in that way, that if you press the leg to make pasta, it will not damage the periostal way. So there is no sign until now. There is no evidence of osteomyelitis. So
Yes, Professor Puruhito. Other question?
I just went a little bit.
Okay, sure, Professor Maliawan.
Okay. the basic concept of the wound healing, whether it's infection or not. Yeah? We are the doctors just to promote healing. We cannot heal the wound. So firstly, you should doing a local treatment. For example, is please preserve vascularization to the wound, and then debride properly, and that including remove all the epithelialized tissue, including the pus also. And then after it's already properly cleaned, then what we think about that? We already preserve the vascularization, and we already debride all the epithelialized tissue. The second one now is the nutrition, and the last then is antibiotic consideration. Not think about antibiotic for the firstly. Firstly, you should doing properly look into the wound. Second, nutrition. The third is a consideration for antibiotic. I just said, because what if you are not doing antibiotic for that? I think whatever the antibiotic you give, it doesn't work for that. Just like this. Okay, thank you.
Yeah.
May I
Yeah,
take a
please. Yeah, please, Dr. Strugala.
Yeah, thank you very much. Professor Malawi Sri, I really agree with you. When we have a small wound, of course, and not with the big pus and not fever, of course, we are using the location only the treatment, yes? Because why we have to give the intramuscular, it's not necessary. But of course, I think the big wounds with the 38 and we still have to give oral antibiotics over intramuscular. But I really agree with you. Small wound, now no treatment, no kinds of inflammation, just only treatment on the location, not to the whole body, because of course it's not necessary. Thank you for your comment.
Thank you, Dr. Strugala. Any other question from the floor? If there is no question, I would like to invite Mr. Max Downham to address the closing session, closing speech for this session. Professor Max, the floor is yours.
Thank you. And thank you for Chudzicka-Strugala and Dr. Puruhito and also Dr. Maliawan. The presentations. First of all, I need to say that I am not a physician, I'm not a surgeon, I am a lay person, and therefore, Dr. Manopo, you always honor me by asking me to make comments, which from a lay perspective, I give. I never cease to be amazed at listening to the papers, the choices that are available in terms of treatment of a patient, whatever the problem may be, and the knowledge and the experience that is brought forward in that discussion or those discussions. I think that there's always the elements which I know well in terms of management, but you, all of you, incur risk and make decisions with risk every day. And so I'm just very complimentary to all of you and really enjoyed your presentations. It seems to me that, again, Dr. Manopo and Professor Talehi and Professor Maliawan and all of the other officers of the Indonesian section, you are to really be commended for undertaking this process of communications, education, and thereby leadership. I think it's fantastic. And so I compliment you all. The presentations were very well done. And so again, Dr. Manopo, thank you for honoring me by allowing me to comment. Thank you very much.
Just a question, Max. When and where will be the next World Congress of the International College of Surgeons? And will it be by on-site conference or virtual conference? Thank you.
Thank you. There are two questions you've asked. We have two bids to host the 2023 World Congress, which will be generally the time, and it's normally toward the end of the year, most likely late October, sometime in November. From the section, Professor Haberall, the president, who has submitted a bid, probably would host that meeting in Alitalia on the coast, but possibly in Ankara. The other bid is from Singapore, from Professor Christopher Chen, who's president of that section. The process, Dr. Manopo, is that I've asked for bids already in mid-March. I will ask them for any updates that they may have in the next few days. The International Executive Council, under the leadership of Professor Lie-Kwan, will then decide and make the selection. So in summary, it will likely be in Singapore or in Turkey toward the end of 2023, and that decision has yet to be made.
Yeah, if possible, I would like to suggest, because the last host was in Thailand, the same area with Singapore. So I think based on the constitution ICS, it should be in Turkey for the next Congress. Should be different continent or different area, if possible. So that's our so possible. We will be very happy, Max, to meet in Turkey, if possible.
Thank you, Dr. Manopo. I will share that with Professor Kwan. I'll be with her next week, and I will with her. I did not answer one of your questions. Will it be in person and or virtual? On the host section that is selected as to how to go about it. At this time, I would guess probably it would be both. It would be a hybrid. Not sure, but so please don't hold me to that, but be considered for sure.
Okay.
Thank you.
Thank you very much, Max, for your explanation. Dear all participants, all speakers, and all others, from the thank you very much for particularly for our guest, Dr. Strugala, and the other speaker, Professor Puruhito, Dr. Indrawan, from the World Executive Officer, Mr. Max Downham, and for the section of speakers, the section Professor Hendy Hendarto, Dr. Francis Arifin, our IT team, Mr. Bimo, and all participants. Again, thank you very much. And we again expect different topic and good morning, good night, stay healthy. Goodbye.
Yeah.
Thank you.
Bye.
Thank
Thank you.
Peter.
Bye.
Thank
Bye.
you, everyone. Thank you,
you.
Max.
Yeah.
Professor
Yeah.
Isa. Isa, thank you very much for coming and attending our meeting.
Thank you.
Thank you, Dr.
I hope
Franz. Thank you.
one more time you will come to Poland and I can show you my job and also my environment.
Of
here,
course,
yeah?
of course.
Okay.
Thank you.
Now we
After
can
the
travel.
war-
Yes.
After the war is over, I'm afraid to come there right now.
Yeah, I invite you now, but okay, you can come to me.
Yeah.
After the war.
Okay.
Thank you.
Thank you very
Okay.
much, dear all.
Thank
Yeah.
you. Thank you,
Goodbye.
everyone. See you. Goodbye.
See you.
Thank you. Goodbye.
Thank you, Doctor.